So, good evening, everyone. I'm Dr. Srinivas Chilikuri. I'm a senior consultant radiation oncologist, and I would be speaking today about proton therapy in musculoskeletal tumors. Before going up to what is proton therapy and what are the benefits of proton therapy and how our experience has been so far, and you can just simply on a just a single slide, you would realize that what is the impact of protons. These are one of the first patients who came to us for proton beam therapy for a musculoskeletal tumor, which this patient had a sacral chordoma. It was a recurrent sacral chordoma, and you can see that you can see the target, and you see the target is extremely close to the rectum, and in fact the patient had a perirectal nodule. And we planned the patient for VMAT and then with tomotherapy. Then we chose to offer the patient protons, and we just did a treatment planning, and you see that there's a remarkable difference as far as radiation beam is concerned, as far as the normal tissue irradiation is concerned. If you talk about rectum, bladder, the pelvic marrow, and so on and so forth, and this could be you can intuitively extrapolate it to several other sites. So what is proton therapy? I think most of you already know about this property, the physical property of proton therapy, which is being a Bragg peak. That means proton therapy deposits its almost entire energy within a short span of volume after they travel a particular distance, and that is called the range. And the range of proton beam therapy depends on the energy of the proton beam. So higher is the energy, higher is the range. So what energies we use at our center is between 100 to 220 MeV. Initially, we used to use from 100 to 220. Now we are using from 70 to 220 MeV of proton beams. These are high energy accelerated proton beams, which are produced by a cyclotron. So the clear-cut defining feature of proton beams is this Bragg peak. Because the dose is completely deposited at a particular range, there is absolutely no exit dose. And that is what differentiates it from the conventional X-rays. Of course, we never treat a conventional single field with conventional X-rays. And similarly, we never use one proton beam or one particular energy of proton beams to treat the entire tumor, because it is not possible to treat a certain finite size tumor with a single Bragg peak, and you need multiple Bragg peaks, and that is how we use the concept of spread out Bragg peak, which is based on multiple energies of proton beams being used to treat patients. Apart from this physical property of the Bragg peak, wherein we don't see the exit dose, and there is the entrance dose is also minimal compared to the conventional X-rays, there is some biological property as well, which makes it a little bit unique. Because these are charged particles, they carry mass. That is why we have a Bragg peak, and very, very similarly, based on the location of the Bragg peak, it's biologically more effective than either cobalt-60 gamma rays or X-rays, and that is what we define as RBE. So radiobiological effectiveness is essentially the ratio of the test beam divided by the dose, the equivalent dose of cobalt-60 gamma ray. So typically, X-rays have RBE of 1. Proton beam therapy, however, the RBE varies depending on the location of where you are measuring the RBE. If you are measuring the RBE near the Bragg peak, closest to Bragg peak, or very close to before it reaches its full energy spectrum, it ranges somewhere between 1.1 to 1.7. And when I say 1.1, it essentially means that dose to dose, it is 10% more effective than the similar dose X-rays. And when I say 1.7, that means 70% more radiobiological effective compared to X-rays. So this makes it unique in certain tumors which are supposedly radio resistant or more hypoxic. These property could be theoretically be beneficial over the conventional X-rays. So there have been multiple advances in proton beam therapy. This, I think, is probably an important message to all those who are not very well aware of evolution of proton beam therapy. Just like we had a cobalt 60 gamma ray, then came the linear accelerators, then came the multi-leaf collimators, then came the IMRT, and then came the image-guided radiation therapy, and then the VMAT and the rest of the other newer advances of radiation therapy. Similarly, proton therapy also has evolved over a period of time. There has been a period when we used to use something called a passive scattering or double scattering proton beam therapy, which is very similar to the conventional X-rays or even telecobalt X-rays, where the dose spillage was a bit higher. Of course, there was no exit dose. That was a unique defining feature. But most of the passive scattering infrastructure, passive scattering proton beam therapy machines all over the world, from 90s to nearly 2010, most of them were passive scattering, and they did not have image guidance. They did not have means to conformally deliver beams. So that led to a significant reduction in the magnitude of benefit what can be achieved from proton beams. However, the contemporary proton beam therapy is called pencil beam scanning proton beam therapy that has been there since 2001 in one particular center that was in PSI Zurich. But there have been the commercial production of PBS was typically after 2006, 2007, but it was still very available in maybe handful of centers across the world till 2012 or so. Till 2015, we did not have image guidance very commonly on proton beam. Of course, there was X-rays, but not cone beam CTs, which is now like a minimal requirement what we must have on a linear accelerators. So contemporary proton beam therapy is proton beam therapy, which is pencil beam scanning. What it does is it delivers those Bragg peaks at the deepest layer of the tumor, and then spot by spot, layer by layer, entire tumor is scanned. So these are the scanning magnets, and the proton is deflected through these scanning magnets to scan the entire tumor. As I said, it deposits its Bragg peak spot by spot, layer by layer, from the deepest to the most superficial layers. And this is how it typically does. And you see that now we are using the newer modern algorithms such as Monte Carlo. We have cone beam CTs, we have image guided radiation therapies. The spot sizes have become smaller. So there has been a major evolution in proton beam therapy as well. Then that is the reason why the American Society of Radiation Oncology has kind of given their expressed their policies as far as proton beam therapy is concerned, because obviously these were given a few years ago. These are not very latest or very not very recent ones, but they have classified the policies into group 1. Group 1 are those class of tumors where based on the medical necessity requirements and published clinical data, these are the sites where ASTRO frequently supports the use of proton beam therapy. That these are ocular tumors. Tumors that approach are located at the base of skull, but not limited to chordomas and chondrosarcomas. primary or metastatic tumors of spine, so spinal and paraspinal tumors, hepatocellular cancers, all pediatric malignancies, patients with genetic syndromes, malignant and benign primary CNS tumors, unresectable head neck cancers, retroperitoneal sarcomas, re-radiation patients. So these are typically the class of indications where Astro supports use of proton beams. Of course, these are group 2 where there is need for more clinical evidence, but these are also sometimes considered for proton beams. So summarizing the role of protons in, especially in musculoskeletal tumors, are chordomas, chondrosarcomas, retroperitoneal sarcomas, sarcomas in children. In young adults, we see such as rhabdomyosarcoma, Ewing sarcoma. Sometimes, rarely, we see those pelvic osteogenic sarcomas, which are unresectable or are partially resected. Those are the ones which definitely should go for proton. There is very good data for osteogenic sarcomas. Soft tissue sarcomas, any location with curative intent could be, because as I said, the radiobiological effectiveness is higher compared to X-rays, and probably these could be candidate. These could be candidates for proton beams. And of course, there are a certain group of tumors which are rare, such as recurrent aggressive fibromatosis, where there is some data, emerging data for use of proton beams whenever the radiation is indicated after, of course, a course of the oral and intravenous and metronomic therapies. So there are 4 categories of indications. If I have to generalize, you would give it where you would expect a higher degree of complications. It could be children because they are because of the nature how they are, and if they are long-term survivors, we are worried about complications. So proton therapy is used for mainly for prevention of complications. Sometimes we have to escalate doses in situations such as chordomas, chondrosarcomas, even some sarcomas we would like to escalate the doses. There is mediastinal sarcoma, sometimes parasinal sarcomas, where there will be a challenge to deliver high doses of radiation. Prevention of secondary tumors. We know that in children, radiation itself causes a little bit of increased risk of second cancers. Of course, that could be one minor indication why one could consider proton beam therapy. And typically, it is perceived that proton beam therapy is for smaller targets. It's not like that. In fact, proton beam therapy is much more beneficial when you have a larger dose to deliver, when you have a larger volume to be treated, where there is a higher likelihood of toxicity. So larger the volume, higher is the likelihood of proton being additionally beneficial compared to X-rays. Protons for musculoskeletal tumors at our center, we have treated a significant chunk. We have treated almost 225 to 30 patients so far. And 56 of them as of now have been musculoskeletal tumors. So we have treated a fairly good number. Sorry. Nearly 20-25% of them are all musculoskeletal tumors. Let me show you one of the characteristic chordoma radiation dose response. We know that photons have approximately 40, 45, 50% 5-year local control rates with conventional X-rays. But you see protons somewhere close to 75, 80. Of course, these are modern series. You see modern series from PSI Zurich and all, it's close to 80%. Of course, carbon ions, theoretically at least, seem to be very superior. They could be ranging from 60 to 80, 85%, sometimes even 90%. Of course, these are small studies with shorter follow-up. Of course, carbon ions are characteristically known to cause a little more toxicities compared to protons because they are radiobiologically more effective, not just to the tumor, but also to the target. So they are radiobiologically more damaging to the normal tissues compared to proton beam therapies. So these are some of, let me talk about chordomas and chondrosarcomas to start off musculoskeletal tumors. Many series, at least these are some of the large series which have been highlighted here. And you can see that the long-term outcomes are close to 75 to 75 80%. Of course, some of them are old series. If you want to see the latest series, as I mentioned, this is from the PSI Zurich. They have used image guided modern proton beam therapy, and you see that the 7-year local control is nearly 71% with chordomas and more than 90% with chondrosarcomas. Of course, the most important is the histology. Chondrosarcomas do much better than chordomas. If they have OAR compression, that means if it is a compressing brainstem, compressing spinal cord, compressing rectum or bowel, or any other structure, we tend to give slightly lesser doses. Lesser doses means lesser local controls as well. So whenever we have those, we always kind of do some kind of a debulking to limit this OAR compression, to relieve the obstruction to the OAR, and then it leads to slightly better outcomes as far as local failure is concerned. Larger the tumor, of course, larger is the probability of recurrence, larger is the probability of metastasis. And of course, whether proton is delivered in a recurrent setting or in the primary setting also makes some difference. So this is a large national cancer database study which has been published. 715 patients of chordomas, 863 patients of chondrosarcomas. This is a systematic review. And you see that patients who do not receive protons have nearly 5-year overall survival of nearly 20%. Compare that to almost 75-80% with proton beam therapy. This is for chondrosarcomas. For chordomas is also very similar in terms of control rates are far better. So there are many issues with proton beam therapy as well. It's not that even in chordomas and chondrosarcomas, results are far superior in patients receiving upfront. So when you treating recurrent, when you have already irradiated once or twice, and then the patient is being considered for protons, the outcomes may not be as good as the outcomes in the primary setting. Results are better in patients without metallic implants compared to patients with extensive implants. So there is, just to sensitize all the surgeons, especially the musculoskeletal surgeons, the metal implants do perturb dose significantly with proton beams. In fact, there have been old studies which have shown that local recurrence rate is nearly 50% with implants compared to 12% without implants. And most of them undergo some surgery because chordoma surgery is extremely crucial. But when the surgeon puts metal to stabilize the spine, it leads to poorer outcomes. So now we have kind of modern proton beam therapy has kind of found some solutions to address this problem, address this challenge. We use multiple proton fields, we use photon-proton combination, we use knowledge of material and understanding. We take the implant and we put it on a CT scanner, we measure its attenuation, we do a CT, a normal KV CT, we also do an NB CT, and then we understand the properties of the metal used or the metal implant used, and then we use Monte Carlo algorithm for optimization calculation. So these are some of the means to overcome the problem of metals. So this is the prescription which we use. We typically treat all chordomas and chondrosarcomas EQD2 of 76 gray. If that is not possible, sometimes it's not possible because it's very close to brainstem, it is involving the spinal cord, there is some disease in the prepontine system, and so on and so forth. We'll have to reduce the dose. So we have reduced dose sometime where we give, we always hypofractionate to get the best out of protons, and VQD2 could extend up to 74 gray. And in the lower dose CTV, which has been resected, receives slightly lower doses. It ranges from 56 to 64 gray at 1.28 to 2 gray per fraction, depending on the location of the tumor. So as far as chordoma chondrosarcomas is concerned, we have treated a significant chunk of patients. Of course, this is not February, this is August 2020. 35 patients were treated with protons out of 38, and a lot of them were recurrent and re-radiations. Very small group of patients had grade 3 toxicity. Some of the chordomas which I would like to show you are the Clivolkodomos. This is one of our first patients, lady Clivolkodomos was resected, very small residual disease. This is one of the better patients where we could actually spare significant doses to the brainstem. Very easy here, but you see that the optic nerve and chiasm were closer, but still we could deliver slightly lesser doses there. This was our first sacral chordoma, which we treated. I think already showed you there was a rectal nodule as well, pararectal nodule. And this was the pararectal nodule. The patient was unable to lie down because of the pain, and we treated in a kind of a semi-lateral position, and we could deliver a good dose. You can see the beautiful sparing of rectum, bladder, and rest of the pelvic bone and pelvic marrow. This was the actual plan which was delivered. We have treated a significant, I treat pediatric patients, and this was a patient of pediatric Clivolkodomos, which this patient had, of course, anesthesia. You see the immobilization. Daily patient had to be treated under anesthesia. This was a large dedifferentiated Clivolkodomos. We could treat those patients as well. And just to inform you that we do not see dramatic changes in the size of chordoma after irradiation, whether we treat with X-rays, whether we treat with protons, or whether we treat with carbon ions. We don't see much dramatic differences in the shrinkage of the tumor. But this study elegantly showed that it takes about 26 months for the tumor to get hard. That means tumor to reduce the size by 50%. So it indeed takes a long time. So we keep monitoring these patients with MRI. But this, for example, this was a large unresectable sacral chordoma involving S1 to almost entire sacrum. And this patient received 70.4 in 32 because of the proximity to the rectum, sigmoid, bowel, and everything, and 64 in 32 the rest of the areas. And you see that February, August, and then current scan. This was in January 2020. Of course, you could see gradual reduction in the size of chordomas as we. This is of course one of the giant chordomas which we have treated. But there is also some hope that there are. We could do some certain MR sequences. We do something called a T1 perfusion, which has been there for a long period of time, but we are prospectively evaluating the use of DCE MR to check for the responses. Sometimes DCE MR shows an early response. If there is no perfusion in the tumor, it's not a T2 perfusion, it is a T1 perfusion. And if we see a T1 perfusion, underperfused tumor, compare that to the original pre-treatment, we know that there is response and the tumor is likely to reduce in size as we go along. This is being looked into as a prospective study, which we are maintaining all the patients' T1 perfusions apart from the rest of the MR sequences. This was the prior T1 perfusion, and you see the current scan as we go along, the perfusion is coming down significantly. So this was one of the retroperitoneal sarcomas. This was an IVC retroperitoneal sarcoma, which we received after several lines of chemotherapy. Of course, it was non-metastatic, and that is why we could take this up for proton beam therapy. And this was our target volume. And we delivered 66 in 30, equivalent of 70 gray. Of course, this was I think, leiomyosarcoma. And we've seen that 3 months post-op, there was anatomical and metabolic complete regression seen in these patients. We know now that from the randomized trial from Dr. Laskar's group at Tata Memorial Center that when we have a higher dose of radiation, it is good for Ewing sarcoma. Similarly, in COG protocols for rhabdomyosarcoma, we are seeing there is momentum towards escalating doses for tumors which are larger than 5 centimeters. And that is how we have treated a large number of patients of RMS and Ewing sarcoma in different locations. This was one of the chest wall Ewing sarcomas which we've treated, and the patient received up to 60 gray. So we are routinely going up to 60 gray now. We'll have to look into where we could go up to 70 gray as well. We have treated certain pelvic Ewing sarcomas as well with with proton beam. So to conclude, proton therapy is standard of care for chordomas and chondrosarcomas worldwide. There is a better OAR sparing for most musculoskeletal tumors. For larger tumors, for larger targets, the benefit of proton is larger. So it is not that, if you have a very small tumor, you may or may not be the best candidate for recommending proton beam therapy for those kind of patients with smaller tumors. Proton beam therapy is indeed actually used better for larger tumors where there would be larger sparing of normal structures. There is always in sarcomas, everywhere we are in almost all tumors, we are exploring the options of de-escalation. But for sarcomas are the only sites where, Ewing sarcoma, be it rhabdomyoid sarcoma, be it chordomas and chondrosarcomas, we are all evaluating dose escalation. And that is where proton beam therapy role comes in. And that is why they are one of the most preferred modalities of treatment for these set of tumors. So as promised, I think I finished within half an hour. If there are any questions, I would be happy to take them. Otherwise, we will call it a day.
Thank you so much, sir. It was a lucid presentation. If there are any questions, please unmute and ask, or you can also use the chat box. Sir, from my end, I have a few questions. As you said that the RBE in proton therapy, it varies with the depth of the treatment, and it varies from 1.1 to 1.7. So, sir, how do we calculate the dose at various depths? Because the tumor is irregular with various depths. And how do you give the constraints to the organs at risk, because they are also at various depths? So the RBE will vary and the dose will also vary.
Very good question. It is RBE. As I mentioned, it depends on where you are measuring with respect to the Bragg peak. So each of the Bragg peaks. And just to simplify, the wise physicists and biologists across the world have made it simplified and given an expression, that given a equation which basically means that the RBE has been approximately mentioned as 1.1 for the entire range of proton beams for different energies, different depths. But as you rightly said, it may not be, it may not be important for the tumor, because it's all right to give a higher dose to tumor. Even if we are delivering, say, 30 to 40% or 20% higher dose to the tumor, it doesn't matter. We don't mind. The problem comes with OAR. So we make sure that the OAR is not the place, or important OARs are not the places where the beam is ending. So if the beam is ending in a parallel structure and a small areas are receiving high doses, it doesn't matter. So most of the proton series across the world have shown that these small islands of probably higher LET and thereby higher RBE do not make any clinical impact of significance. If that is why we ensure that the proton beam is not ending on the brainstem, or all the proton beams are not ending on the brainstem. If they are all ending on the brainstem, we may expect a higher rate of radiation necrosis. So we make sure that the proton beams are not ending on the brainstem. We use multiple beams of different directions so that they don't end on the same place. They don't end in the same place. So that is how we equate. So we basically simplify it by making all the calculation of proton, on the basis of RB being 1.1, which is definitely an approximation. There is now a newer system, treatment planning systems, which are incorporating the LET of the protons. So it is called LET based optimization. If that is started, probably it will be slightly more accurate.
Okay. So, sir, there is a question from Dr. Ajay Shashidharan. What is the maximum dose delivered with protons for sarcoma?
So as I mentioned, we at our center, we are delivering up to 76 gray EQD2. 2 gray equivalent, we are giving 76 gray to chordomas, nearly 74 gray to chondrosarcomas, 72 gray with osteogenic sarcomas, large pelvic osteogenic sarcoma or mandibular osteogenic sarcomas. Or if it is a soft tissue sarcomas, we go up to 70 gray, 66 to 70 gray. As I said, we almost always do hypofractionation whenever possible, except in children where we are using conventional fractionation. Ewing sarcoma, it ranges between typically 50 to 60 gray, depending on if it's a large Ewing sarcoma. Unresectable Ewing sarcoma, we are trying to go up to 60 gray. If the evidence comes for more in a particular location, probably we'll look into it. But as of now, we are going up to 60 gray for large unresectable Ewing sarcomas. Rhabdomyosarcomas, we go up to 50.4 typically, but there is some data now for larger than 6-7 centimeter. The COG, all the COG protocols are using 59.4. So we use 59.4 in those large RMSs as well.
Okay. So, next question is sacrococcygeal chordoma post-op with residual lesion had gluteus muscle involvement. CTV, should it include muscle for definitive dose?
Oh yes, absolutely. In fact, chordomas are known to involve skin, subcutaneous tissue, muscular planes, muscles. It is fairly large volume when we irradiate a chordoma, especially the glutei. When we use sacral, sometimes I use up to 2.5 centimeter margin, CTV margins beyond the gross tumor, because it is like a jelly. I mean, it has multiple forms and it goes very, very deep. Because we are seeing the clear natural history. When we see recurrent tumors, we know where they are recurring, and that is why it is extremely important to extend the CTV much beyond the tumor. So it needs to be very, very liberal. You cannot be conservative when you are defining targets for chordomas.
So, sir, from the conventional photon therapy, is there any difference of immobilization and simulation? And can we simulate the patient on MR? Like, can we plan the patient on MR based treatment in proton therapy?
Yeah, of course. We always do CT and MR based planning. All sarcomas, I think, without MRI, it's not possible.
Uh,
We take multiple sequences in MR. In fact, there are many sequences which need to be taken depending on the location. Some special sequences also probably will be used. The simulation is also depends on what beam angles are going to be used. Is it going to be prone or supine? Sometimes for certain, for example, sacral chordomas, sometimes we use a prone position. Clivolkodomos or rest of the sarcomas are treated as per. I mean, but it needs a little bit of individual attention as far as what is the patient position is going to be, what are the beam angles are going to be. So it needs a little bit of pre-planning. We do something called a pre-planning audit in all patients before they go in for simulation, because we sit with therapists, we sit with physicists, and we kind of discuss what. Now of course we know a typical patient comes, we know what is the beam arrangement to be given, but there are sarcomas can come anywhere, so we always sit and discuss what are the best beam arrangement and everything.
Sir, just the question, like we need
Sorry,
execute the treatment.
sorry, I could not hear you.
Audible? Hello.
Now it is better, please go ahead.
Hello, am I audible?
Yes, now you are.
Okay, okay. So, sir, just like can we skip CT scan? Means in the planning system of proton therapy?
No.
Is the system no? Okay, that's what I wanted to
The
ask.
the stopping power of protons are based on the CT data. In fact, we need if it is possible, a dual source, dual energy CT are even better to have a better understanding about the stopping power of protons. So CT is extremely important, as important as for photons.
Okay. And sir, another question is, because we have a higher RBE, so can we skip surgery in the patients using proton therapy because of its higher RBE, and we give radical dose? Is it possible? Like, can we give that?
See, I don't think we'll have to redefine the oncology principles just because we have a better modality. I don't think we can do that safely unless we have a tremendous data for it. So we wouldn't change anything as far as surgery is concerned for any sarcomas. I must say that surgery is always the first choice, without a doubt. Be it a soft tissue sarcoma or is it a bone sarcoma, surgeon is a very integral part of the management team, and they will also they will guide us in many ways for patients. Of course, we are there in certain situations where the surgery is associated with a lot of morbidity, but I am fully convinced that radiation alone as a modality is to be used for very selective patients only in sarcomas. Of course, exceptions are pediatric sarcomas, round cell sarcomas, which are extremely sensitive to chemo and radiation.
Okay. So, are there any other questions from the audience? So, I thank you so much, sir, for spending your precious time to educate us all. And we look forward to more learning from you, sir. Thank
Yeah.
you. Thank you so
My
much.
pleasure. My pleasure. I
Thank
hope I was able to stick to the time.
Yes, it is. We are really thankful, and we look forward to more learning from you, sir. Thank you. Thank you so much.
My pleasure.